we have received some questions ahead of schedule or ahead of time that we're really excited to get to. Cindy, if you're okay, I'm going to go ahead and get started.
Okay,
Okay,
I'm ready.
I got to open up my email because that's where I got them, which I was so excited about. Okay, first question. With expanded value-based purchasing on deck, I got to move some screens here. Hold on. For 2022, and that payment strongly impacted by functional improvement metrics, how can agencies afford to grow or even sustain skilled maintenance programs?
Well, I just want to, before we get into that question and some of the other questions I know we have on the list for today, is may have some folks that are new to this process. This is really a open mic type Q&A. This is not a formal presentation. We aren't going to bring out slides and charts and graphs, but we want your participation. So as it says in the chat box, if you have any questions related to the one Sherry just asked or anything else that comes up today, go ahead and put that in the chat box. We're happy to include our live participants. But I just want to make sure you understand that these are going to be more free-form responses, a little bit more opinion, live mic type things. So I want to just make sure folks understand that Sherry's question about do we still want to pursue maintenance in a value-based purchasing environment, my responses and Sherry's responses to questions today may be a little bit more edgy. I just want to make sure folks know that and don't go, oh my gosh, I've never been to a Cornettian craft thing. Is this how they present? Well, sometimes yes, but we want to make sure we're providing our thoughts. When it's an opinion, we're going to clarify it's an opinion. And if ever a question is looking for a definitive regulatory resource, which is what happened in our last Q&A, we make sure to find that and to get that back to you so you have the information that you need should that situation arise. So back to the value-based purchasing issue, Sherry.
I think they actually count on us to be a little edgy, Cindy, and that's probably more entertaining than just the same old vanilla stuff that they hear at conferences and that.
Yeah, I know. Even at conferences, we get a little. I know I do. And you came out of the gate. I didn't know which question you were going to pick first, but you came out of the gate with a topic that is just kind of pinging me with respect to this value-based purchasing issue. And there's a variety of things we could talk about, but let's focus on the maintenance issue. Yes, I agree that when you look at the items that influence the calculations for value-based purchasing, there is a chunk of them that are functionally related. I think we need to be cautious by always looking at those through a therapy lens and saying somehow our utilization of therapy is the hugest deciding factor in how those outcomes are calculated. I say that because overwhelmingly, I have not encountered an agency yet that 100% of their Medicare patients are being seen by therapy, at least evaluated by one of the therapy disciplines. There's still a significant chunk of Medicare patients coming through the home health services that are never even evaluated. And yet those same patients have those same functional questions answered at the beginning and end of care, and an outcome is calculated. So I always hesitate to say what therapy does or does not do is the sole defining factor of our functional scores. Um, so with that in mind, also understanding that value-based purchasing is going to be pulling from a very specific group of patients. That fee-for-service Medicare is what they built the original model on. So other payers, other situations where maintenance may be appropriate for them, we don't even need to think about whether or not that affects value-based purchasing. We're talking strictly about this group of patients. That being said, when you look at the report for the findings of the fourth year, the summary report really of all 4 years, what they talked about most was not the quality changes. They basically referred to them as minimal or nominal with respect to any sort of improvements or that pilot group being better at outcomes than the rest of it. Their big emphasis was cost control. The savings to the Medicare program was coming from looking at when they were under our service and the 30 days post. Did they end up in the hospital? Did they end up in a skilled nursing facility? What was their emergency department use? So when we look at the driving forces why they want to expand it, it has nothing to do with in value-based purchasing, you got better functional scores and everything to do with how your efforts manage to control Medicare cost. And what's interesting in that summary report is it's a very quick line. It's a very brief statement, but it jumped out at me and it's going to show up in my training, Sherry. It has to.
Okay.
There was basically no change to the expenses for home health. In other words, those agencies, from a cost standpoint, didn't do really anything different in terms of utilization. It didn't increase home health spending. It didn't decrease home health spending. So what they saw was our spending stayed the same, but they looked at it and said for these patients, they were less likely to be back in the hospital. There was a significant decrease in their utilization of skilled nursing facility services. Again, within our episode and the 30 days post. And they did actually see a slight uptick in ED without admission. But the overall issue was it saved them money, which is why they want to keep going. So we're back to maintenance. If we're saying that the outcome issue was very small with respect to what they saw in looking at those adjustments versus the control group of the rest of the country, and their emphasis was on keeping them out of higher cost care, then maintenance makes absolute sense when used appropriately. Because that is one of the driving forces of it. Clearly, it's not about improving their function. We know these are individuals where that's not reasonable, but we're trying to slow or stop potentially the decline. And if we're able to do that while we have them and looking beyond when we have them, which is why it's so important to set up an effective maintenance program that can be carried out after we're gone and we don't need to be seeing them anymore for skilled services, that if they are able to now stay out of a skilled nursing facility, that is a huge gain when you look at value-based purchasing. So I fully appreciate, Sherry. There seems to be a disconnect. There always is with these measures, whether it's value-based purchasing, our stars ratings, our home health compare scores. Everything says improve function, improve function, improve function. And folks on the Medicare advocacy side, and many of us have argued and advocated to CMS as you refine your measures, as you look at these, you have to refine and acknowledge the stabilization element. I think the more of us push back on that during comment periods or whatever opportunities we get, ultimately we will see that move. They argue that those composite numbers, because I was part of the home health value-based purchasing technical expert panel, those composites indirectly don't penalize you for stabilization. My argument has been, although that might be true in the fancy schmancy math calculation, it's kind of hard to see it when the measure talks about improvement. So we need to keep advocating for a refinement, but I think we also need to understand what CMS's emphasis is on this is not so much that our individual quality components got better, but did we keep them out of higher cost care?
And I think that leads right into the second question, but I have a personal question to ask you, Cindy, and I've kind of been writing about this in our email blasts. What
Hmm.
do you think is going to happen when the proposed rule comes out at the end of October? Likely the end of October, usually somewhere around when they used to hold knock, but usually somewhere around the uh, Halloween, right? It's like
Hmm.
like Halloween's not spooky enough. We're going to get the final rule.
We
What
always
do you
get the proposed rule at 4th of July. So we
Yeah.
get the proposed rule at 4th of July and then the final at Halloween.
So what do you think is going to happen? Do you think they're going to expand it to 50 states in January of 2022?
I would be shocked if they didn't, Sherry. I just, when you look at that report, especially because that report came out in May of this year. In January of this year, prior to the final year report, so they only had 3 years worth of information then, they released in January a public announcement that they had already been certified to expand the program to all 50 states. I
Mhm.
think part of it is these innovation programs. If you look at, this wasn't the only one, there were multiple, but many have said the home health one is probably been the most financially successful and compared to some of the others could be seen as one of the very few that actually worked as they had hoped. So I think they're also looking for a win. And if this was a win on a small scale, why not throw it out there and see what happens? Because part of the summary report basically also said that states already in it thought it was great. Now,
Mhm.
I don't know I don't know how true that is for every single agency, but if they're saying the home health agencies didn't complain, home health agencies didn't close over it, spending was the same, and we saved all this money just in 9 states, I'm not sure what you could throw in their path to say, "Yeah, okay, we heard you. We'll wait. We won't expand it now."
Well, and with some of the conversations that are coming out of DC where they're trying to pay for a $3 trillion infrastructure bill,
Mhm.
it doesn't look to me like they're going to throw away an opportunity to save any nickel or dime in home health. I just don't think that that's the mood that's going on in
Right.
DC right now.
No,
But
I
that
agree.
kind of leads us into the choose home health or choose home bill that's out there. And I've been kind of sending out emails for the last, golly, 3 or 4 months, asking people to reach out to their representatives and let them know what they think about the Choose Home bill. Basically, the Choose Home bill is a way to put a little bit more money into home health to route people instead of the hospital and skilled nursing being at the front of the line for the acute patients that usually need that higher cost center of care. The Choose Home bill incentivizes those being sent home, and making home the center of care versus those higher cost centers. So if this includes an additional home care payment, I'm rolling into a question, Cindy. For the
No, we're good.
intensive therapy nursing aid needs of the patient who qualified for skilled nursing but chose to stay home instead, doesn't that recognize that PDGM and or its current I've been tripping over this word all day. Operationalization by agencies is not meeting the care needs of this patient population?
I think the person who asked the question, the part that jumps out at me, and not just because you struggled with the word, is PDGM and the operationalization of it. I think we need to be careful about attributing decreasing utilization to the PDGM model in and of itself, because we always have to look at how did they build it? And when they were putting together this refined set of characteristics, getting us off the prospective payment system for the last 20 years and looking at a different structure, they ran the model many, many, many times, utilizing our data from previous years. So using that 2019 information, using that 2018 information during testing phases. Those were looking at utilization, and let's just own the elephant in the room on this one. Higher therapy utilization was going on in 2018 and 2019.
Yep.
They acknowledged that there's a cost with that, but that the whole 6, 14, and 20 thing potentially was influencing utilization. But when they calculated the new payment groups, they utilized our own behaviors from the years prior. So the utilization of nursing, therapy, aides, social work that was going on before PDGM, the intent was for it to be paid comparably in PDGM. So it was never meant to say we're going to take what you made, take a chunk out, give it to you, so you do less, so you can do less under PDGM. I think yes, no model is perfect. The PPS system wasn't perfect either. We knew when you would run case mix weight on 2 patients, there were times where you'd go, "Oh my gosh, this patient is got a whole lot of money and doesn't really even need this amount of care. And this other patient, my gosh, what they came out with for their case mix weight is nowhere near what we need to provide the care," because it was meant to be a we win some, we lose some, we look at the big picture, not an individual patient's budget. So when we look at this issue now and say, well, if that's how they built it, they didn't really anticipate there to be big utilization changes in PDGM because again, they're saying, all right, you guys did what you did in 2018 and 2019. You said it was because it's what the patients needed. Therefore, we would expect this pattern to continue. And if you look at the proposed rule for 2022, there's very interesting data tables in it looking at utilization and how using 2018 data running it through PDGM, what they expected utilization to look like based on that, And then they ran it again with 2019 data. And interestingly enough, there wasn't very much difference in the number of nursing visits, therapy visits, aid visits, the whole thing. Maybe little bits, but nothing significant. Then they ran 2020. And it's like, okay, what happened? Because the therapy visits tanked. And I understand, and I'm coming back to the choose home thing, Sherry, but I want to make sure we understand the utilization element of this. Is the model wasn't intended to drive down utilization. 2020 data indicates it happened. Yes, we could open up a whole other conversation about how much of that was PDGM versus the pandemic, but February of 2020, before things really came off the rails with the pandemic, Medicare was already becoming aware of therapy utilization being ratcheted back to the point beneficiaries were complaining, and they
Mm-hmm.
sent out an official MLN to basically say coverage criteria hasn't changed. People who need these services need to get these services. So why am I going there to then the choose home issue? I think what's very interesting about Choose Home, and I think it's personally, I think it's a great idea. I think that there are patients, and the pandemic put an additional spotlight on that, that don't really need to be in a nursing home. Okay. Yes, they have higher needs than maybe we expect to manage in home care. But if they had a little bit more support, particularly more of an hourly aid type access, they could be managed at home.
Mm-hmm.
And that's great. But what I think is very interesting is for all the support that's being garnered for this and this is good, this would be great, this could be it's something new for us to wrap our arms around. There's some interesting silence from some key Medicare advocacy groups. Their argument is this: if you look at the actual Medicare Part A home health benefit, folks are entitled to way more aid than they're ever getting.
Yep.
And if you look back at that without PPS, without PDGM, you just look at it, the benefit already says they can have this. And advocates have been fighting with our industry for years about, no, what do you mean the aid only goes? Well, if we go past prior to the year 2000, when we were paid per visit, I remember when giving people an aid every day was like rewarded. Hey, give them more aid, give them more aid. We went into PPS and suddenly aid use shrunk.
Well,
In
I think the home
PDGM,
health
it
aid,
shrunk.
yeah, the home
But
health aid became a way that agencies tried to save money.
yes,
They actually tried to save money on it, and I'll stick in there. If you a lot of folks out there in the industry think that if they have a patient in the assisted living facility, they're like, "Yay, we don't have to provide an aid." Yeah, that's just not true. So go ahead, Cindy. I'm sorry.
no, you're absolutely right, Sherry. And please feel free to interrupt me because when you ask me these kinds of questions, I can get all wound up. Um, but so their silence in not really taking a position on choose home, I think is interesting because what they're saying is PPS and PDGM have ruined and interfered with what the benefit actually says for years. And because they put payment models in place and agencies adjusted what they were doing, whether it was, I'm going to save money by reducing aid, or I went into PDGM and I'm ratcheting back my therapy. It's almost like a vicious cycle of they change it, we change what we do. They say, oh, okay, so now you're saying this is all patients need from home care. You get in, you get out, you do a few skilled services, you give them a couple of aid, and you're done. We're now arguing, well, no, that's what we have to do because of your payment model. And CMS says, well, no, because this is the payment model. You're still supposed to do what patients need. And so we're kind of trapped in this. But I think about the choose home, yes, it's one thing to say if we go back to its purest form and look at the actual benefit, there absolutely should be more aid going on in home care. There's X number of hours allotted in the benefit. It actually says it.
Mhm.
But we've been kind of driven away from it through payment methodology and attempts to try to manage that have now put us in a point where some are saying, well, some elements of this choose home idea you could do now, you should have been doing, but we have a payment methodology that doesn't necessarily align with that anymore.
Mhm.
And so we're seeing some, how come we're not seeing certain groups just jumping on with choose home? I think there's some validity to the benefit already had some of it in it, But I think we're so far down the payment implications that having to come at it from a different direction is probably going to be what it takes to kind of right the ship in a way to be able to get there. But I do understand that you look at the benefit, you look at how our utilization was prior to prior to PPS, and then per visit went away and BID nursing went away. Give them an aid every day. All this other shifted so far the other direction that it looks like home health is very much a short-term minimal visits, get them out. And we say, well, that's all the payment system's fault, when in reality, the benefit itself hasn't changed what beneficiaries are truly entitled to. So Sherry, you're a previous agency owner. I mean, how do you kind of look at that and say, yeah, I mean, I understand what Cindy's on a rant about, what the benefit says, but I still have to be fiscally solvent. I mean, how
Right.
do you kind of,
For me, it was always the golden ring, if you will, was the interdisciplinary care. So if you look at the aids as being a cost center, and you look at the skilled nursing, well, historically we've always looked at therapy as being a revenue generator, and then nursing being a cost center. All those things are just kind of overgeneralizations. If we truly could get to interdisciplinary care, where the aid could be almost like the scout that makes sure that identifies a problem quickly and helps to determine how much of the skilled disciplines that you put into the house based on the actual status of the patient, because the eyes are on the patient. I think that's where the revenue management place lies. I do not think it is in parsing visits. We need to take the word visit and just bury it, to put it down in the dirt, cover it up 6 foot under, and never say the word visit again. And I know that for LUPA standards, you have to still keep an eye on the LUPA and not lose the opportunity to work with patients as much as they need. However, the word visit is just really gotten us caught up in a pickle, because every time we say visit, we think a dollar sign. A lot of folks in the financial level, at the financial level of your agencies, that's all they think. They say visit equals money going out the door. And honestly, if we could truly get to interdisciplinary care where everybody communicates, and the only one that goes out and sees the patient is the one that absolutely has to be there that day, that's where budgeting and keeping your profit margin lies. I really do believe that. And incorporating the new things like telehealth and all the technologies that we have in a way that's responsible for the patient, the way that the patients understand. Because remember, I'm 55. I don't have a problem admitting that. I am a brand. I never grew up with computers. I don't have that. But the generation that's coming up behind me is going to be completely computerized, and they're going to have an expectation for that. So preparing your agency now, getting those folks that are tech savvy and will welcome the new things that are out there, is another way that you can manage your revenue. Is that kind of what you were looking for, Cindy?
yeah, well, Sherry, yeah, actually, I really, really like these Q&As because as you're talking, I start thinking other things.
Yeah.
You know, we've always looked at it, like you said, aid, how do we control costs? Well, we'll reduce the aid. So as opposed to an aide going 3 times a week, we rather send the nurse 3 times a week.
Yeah.
Well, which is actually more expensive. I mean,
Absolutely.
in terms of if the nurse had, if the more touches in an episode, and again, when it's appropriate for the patient, I'm not saying this is a model
Hmm.
for every patient, but if they had touches with the aide where the aide could say, yes, they're doing their exercise program, they're doing really good. I don't, PT can, this is what I'm seeing. And then we could make visits when it almost using the aide like a human telemonitor in a way,
Exactly. Yes.
to say, what are you seeing? Okay, where do we come in? And again, we're not going to turn aides into nurses and therapists, but what are those things that we can help them on? What are those triggers they need to be looking for that say this warrants a skilled visit versus everything is just on the calendar? And I think that's where, to a certain extent, PDGM and revisiting the utilization issue is important because I think too many clinicians get very habitual in how they dose themselves. That's the term I've been sticking on now, Sherry, about dosing ourselves, not visits, but how are we dosing
I like it.
ourselves in terms of what they need. And you and I look at a lot of care plans and it's like, really? Doesn't seem to matter what's wrong with you. You're always twice a week for X number of weeks, or 3 times a week for X number of weeks, or you're always this number. And, it doesn't matter if you're ragingly demented and have a big open wound or you had your knee replaced. It's the same thing. Well, that doesn't make any sense in terms of patient-specific care, but it's never made any sense to CMS, because that's why when we look at our payment thing and say, well, how come there isn't anything in PDGM about their caregiver? How come in PDGM there's nothing specific about cognitive stuff? How come there's nothing? Well, yeah, because they've looked at our data and they say it doesn't matter if you're demented or not, you're getting the same number and kinds of visits, which means your cost is exactly the same with or without dementia, with or without a caregiver. So why would
Mhm,
I pay you differently for someone who doesn't have a caregiver when you make the same number of visits to them as if they do?
mhm.
So I like that kind of. I think we've struggled, even though it's 20 plus years now of being in episodic payment. I think we've still struggled with that visit and what we do, and not viewing it as managing a patient for a period of time. And I think it all goes back to, not only is it the financial people looking at it, but quick little soapbox, we still haven't figured out what to call productivity any at this point. 20 years later, we're still talking about visits per day
Yes,
in a
absolutely.
model in a model that says manage them for a period of time. We're still valuing our own staff by the number of visits they generate per day, and not saying if you spent a couple hours calling 10 people as opposed to driving to see one, we could manage patients better and you
Mhm.
are actually being productive.
And I think that that's honestly what value-based purchasing is trying to get to. And I just want to stick a little macro perspective over this. We're not hearing from those large agencies out politicking to have choice, the choose home bill passed. Because they think it's going to be an additional cost and we're not going to get reimbursed by Medicare enough to cover those kinds of services. But on the flip side of that, I just want to let you guys know, if you follow the mergers and acquisitions that are happening in our industry, first of all, your head will spin. Second of all, I've seen a distinct move towards the large players buying private duty agencies. A distinct move. In fact, the last probably 10 or 12 that I've had notification of have been the large players purchasing outright private duty nursing entities. Now, I hope that that is so that they can provide the aid services and have enough aides to provide those medical aid services. Oh, I like that term, Cindy. Let's keep that one. Medical aid services are different than private duty services. When we provide those medical aid services, you have to have the staff to do that. And I see that these agencies are aligning themselves to have a pool of staff that they could possibly train to go into that choose home health. However, I hope it's not so they can have a captured audience or a captured number of patients that they can throw over to their private duty side when the aid demands become too much. I think that that's a backlash that this industry does not need to see. But I want to stay on PDGM, Cindy, and I just want to remind everybody that if any questions come up during our session, please post them in the Q&A. If you have anything you want to add, if you have a story you want to tell, please post it in the Q&A and so that we can get to you guys. But Cindy, if you're okay, I was going to move on to another side of this PDGM question.
Okay.
Okay. So, um, do we have any advice and anything that we can lend towards PDGM and allocation of visits? Again, I want to bury the word visit. So let's say allocation of resources, allocation of
Mhm.
therapy resources across the therapy disciplines. And how do we have any insight into how therapy companies have been successful in navigating their desired amount of taking the visits word away, desired amount of visits? I'm changing that desired amount of patient contact when they send in, because what I'm reading, and I'll kind of clarify this question. What I'm reading is that therapists are frustrated. They turn in a plan of care that has 15 visits on it for a patient. Again, I hate that word visit. I've now become to loathe it. Um, and they get back that no, you can go 4 times. So what do we say about that?
Well, also, we're getting some activity in the chat, and I want to acknowledge that. We're not saying that no, we wouldn't look at visits at all. I understand that visits are how we quantify cost,
Hmm.
and that we do need to be looking at that operationally. And weighing those resources. And yes, some agencies are very much scrutinizing their utilization of an aid. Others have said that they're not going to, they don't really look at that as an expense. Every organization is different. When we speak to what we're seeing, it's not just a single agency experience. It is looking at the groups of clients we've worked with over the years and our current clients, and identifying those trends. So yes, visits are part of the conversation. I think the reason we're talking about loathing them is sometimes they become the only piece of the
Hmm.
conversation or the cornerstone of the conversation,
Hmm.
and not really looking at what are we trying to achieve. And that's really what outcome-based care is supposed to be about. Here's your pot of money, here's the number of days it covers. Now you look at this individual patient and you figure out what is the best mix of resources to accomplish what needs to be done for this patient. So visits will always be part of this from looking at cost, but how do we then figure out that allocation of visits piece that's in the question you asked just now?
Hmm.
I think I'm going to be, maybe a little extra candid for a Friday,
Okay.
as a therapist. I think therapy utilization, if we go back and look at it under PPS, there were clearly times therapists were getting to write whatever they felt like writing because the more you did to a point meant more revenue.
Hmm.
And if we look at nursing prior to 2000, back to the per visit day, and when we went into PPS, nursing visits took a hit. There was a lot of, do they still need to be there? The BID wound care, we got to find a better way to do it. We need to make some changes. Now, does that mean it was all horrible? It was all just a financial decision? I would say no. Was it really the best possible care to be seeing people BID indefinitely? Or was it a wake up call to say maybe some patients should be managed that way, but maybe there's better ways to do things that are more effective? But at the same time, nursing was getting the what can we do differently? Let's look at telehealth monitoring, because if we have a monitor in the home, the nurse doesn't have to go as much. All of those conversations, nobody was really talking about that with therapy. I mean, tele-rehab is not new. It was not invented by the pandemic. It's been around for a long time. You'd see them at therapy conferences. You'd never see them at a home health conference. Why? Because nobody wanted less therapy visits. Let them go to the home. Oh, I want a discharge. Can't you stay another week? Can't you go a couple more times? Can't you do these things and we'll get the nurse out and you go do these things? You don't really need the nurse. Give them all this therapy. Well, there was positives to that too by expanding and having us utilize our full scope that we're able to do as far as managing patients. But I think the lack of scrutiny led to this. I can write, I know they need 3 times a week, for 4 weeks, and I know that this is what they need to do. And I think PDGM, by ending that idea that therapists are ATM machines, to say, now really, what do you need to do? And I think we've seen some of it rebound too far. I asked for 15, you came back and said I get 4. Okay, we're way off here. But how do we have a conversation about when therapy needs to make that visit? When do we need to be there? What are we trying to accomplish for this individual? Is 3 times a week or 2 times a week on basically everybody really what this patient needs? Is this patient receiving nursing, PT, and OT orders? Is totally overwhelmed, just got out of the hospital, has all these things going on. Well, if I was that patient and I'm having all these issues going on and all these people come in my house, I would be more interested in managing my self-care a bit better than I really would be about whether or not I can get out of my house right now from a mobility standpoint. So if I'm overwhelmed, maybe some OT first and bring PT in a little bit later when the patient's feeling a bit better and is able to get their clothes on a bit better and feeling better about themselves before we get into some of these other things, could make a lot of sense for a specific patient. It also could be that we say, do I really have to go this often? I've given you an exercise program. You have a reliable caregiver. I've seen you a couple more times. This is going well. What we're doing is effective. I only need to see you once a week. And yeah, oh gosh, that's maintenance. Not necessarily. I can do one time a week as a restorative focus of care. I can go once every other week. Is the patient plugging along with these services and doing well? And to me, Sherry, the example that is always stuck in my head, and this goes way back in the time machine as a rehab director. When push comes to shove and we were short staffed for therapy, or we're getting slammed with evaluations, the patients that always got prioritized were the orthopedic patients.
Right.
And it drove me crazy. I'm like, why? These are typically fairly able bodied people to begin with. Overwhelmingly, these are elective surgeries. They had therapy in the hospital. So they already have their exercise program and their equipment underway. Sometimes they're coming to us from rehab where they've already been, I don't know, rehabilitated for days before they came here. Why are they jumping the line off of these multiple comorbidity, frail elderly, probably didn't even get seen in the hospital by a therapist because, it was pneumonia on top of their COPD, and they got sent home? Oh, because they have a spouse who can take care of them, who's older than them and has 10 more comorbidities. Well, those can wait. And then when we see it, oh, those ortho people, oh my gosh, they need 3 times a week. Oh, this poor guy, oh, he's really sick. Yeah, he's twice a week. And he'll start next week, when we have more time.
Mhm.
It's just like we have to look at this and say, yeah, again, I asked for 15, you give me 4. Do I think 4 is enough? Probably not. Do I think it's worth evaluating if 15 is too many? Yes, because we have to be able to defend that decision. And I think it's
But
unfortunate that payment makes that happen, Sherry, but I think we've had 20 years of therapy just saying this is what the patients need. And everybody goes, okay, is it more than 6? Is it not 27? Is it 22? I love it. Best number ever.
and someone just put into the chat box, at least theoretically, auditing or skilled, reasonable, and necessary documentation should be the guardrail, right? And
Uh-huh.
it gets,
Yep.
in my mind, it gets back to that interdisciplinary care.
Yep.
If you guys go into that meeting, and I'm not saying that you have to share all the financials from every one of the things, because there's so much more overhead in home health agencies that a lot of clinicians don't understand. But if you go in with the thought of, we're going to give this patient everything they need and not one thing more, then things like, and Cindy, I'm about to ping you again. Are you ready?
Yep.
Things like the skilled nursing start of care for the therapy plan of care.
Oh, yes.
That is, talk about a huge waste of revenue. Why are you not expecting that everybody on your team that is able to do the admission does the admission when it's appropriate? The pandemic allowed us, the PHE changes allowed whichever discipline was first available. If all three were, say they ordered OT, PT, ST, and nursing, that whichever is the most available or most appropriate could go out and do the admission. Yet we still see every single day where a skilled nurse will go out and do the admission and write no plan of care, and then the therapist will follow. That to me is a relic. It's archaic, and it's really honestly a waste of resources. And so those kinds of things could be addressed and possibly mitigated if we had true interdisciplinary care.
And
And
Sherry,
and go ahead.
no, go ahead. No, I think that brings up, if we're going to do that, and what would those guardrails be about underutilization? I know some people will flinch.
Yep,
I think it's the case conference. I think
absolutely.
it's a well-run, okay, this is the therapy is proceeded. I've only seen them twice. And what is the aide seeing? What is the nurse seeing? This person's not doing very well. They're not bouncing back. They're still having a lot of trouble getting around in their home. Okay, then I think we need to increase it. I think that really talking about being each other's eyes and ears in a well-run case conference can be that guardrail to say, all right, I again, 4's too low, 15's too high. Maybe I'm going with 9. And I try that. And the patient may do very well. And I say, okay, this is lesson learned. Everybody, I'm getting good feedback from the team. This is progressing nicely. I'm getting feedback from the team that it's not. Things are going badly. And I think therapists kind of do this already when we're out in the home and it's like, okay, this is a therapy only. Where's the nurse? I've seen enough evidence based on what's going on with this patient, that nice little bowl of meds on the table that they can't identify half of it. They're definitely, you know what? I'm getting a nursing order. I'm going to
Mhm.
find a nurse to make sure I check this. I think, looking at the, and I think some folks probably get aggravated by this conversation, in terms of, well, this is just very basic. But I think we've made so many layers of all these quote requirements and all this other and all these reports and all this data that we're basically choking out the clinician. And the clinician is the one who actually drives this whole thing.
Mhm.
I mean, their decisions make or break all of it. And I see a lot of leadership people staring at reports and wringing their hands. And how do we make them do less? And how do we make them do this? And how do we make them stop messing up the oasis? And how do we make sure they turn in the documentation on time? And all of that are important pieces, but we're losing the clinical decision making. A good friend of mine, they're actually moving their structure. Their structure has been a rehab supervisor for the therapists and nursing supervisors for the nurses. They lost a couple nursing supervisors. They have not been able to replace it. So are you ready, Sherry?
Go
They're
ahead.
going to make them supervisors of interdisciplinary teams. So
Stop
get
it.
get rid of the rehab. And so there's 3 teams. One is run by a nurse, one is run by a PT, the other one's run by an OT. There's your 3 supervisors of interdisciplinary teams.
That's awesome.
What's interesting though is the therapists who are used to supervising therapists. And please don't anyone say that's because you're a therapist, you're bi. No, when it comes to something like scheduling or autonomy, therapists tend to run themselves that way. I'm going to set my frequency, my duration. Here's my plan of care. And
Mhm.
I'm probably going to be the only one seeing them unless there's an assistant, blah, blah, blah. We have much more control over that typically. Since they've moved to this, the 2 therapy supervisors are pulling their hair out because I'm just going to say what I'm hearing. They feel like the nurses don't even feel like they can make a decision. They're calling the office all the time. Well, I have all these people on my schedule. What am I supposed to do? Oh, which ones can you keep? Which ones can't you? Which ones are yours? I don't know. Well, what about, I don't know. Phones ringing all the time. What have we done to the clinician? What have we done to the nurses by all this jigging around and they see 10 different people all the time and they don't know who their patients are? And I think that kind of, I'm just running around, sorry, Sherry, making visits is not really managing patients.
Nope.
And do we need to step this back and say, okay, what are we trying to do in episodic management? What are we trying to do from outcomes? And it's not just, and the value-based purchasing thing has me all riled up, Sherry, because it's really about the care that happens in between. Yeah, my
Yes.
OASIS needs to be accurate to measure it right. I get that, but you can beat that OASIS to death and still not have the outcomes you want because the people providing the care in between are saying, this isn't an OASIS time point. I just do what I do. So I don't want to oversimplify it, but I think we've gotten all into these other things and lost track of the core of what home health is. And yeah, we need guardrails. Yes, we need to keep an eye on things and review OASIS and make sure somebody knows how to code this correctly. But I think we get just so aggravated and we're not achieving that. And we're back to, now you can only do 4 visits. Based on what? What conversation have we had about what this individual patient needs?
No, exactly. And I heard a woman who I respect very much, who has a very successful agency up in the Indiana, Ohio area. I think she covers both states. And she said at its core, home health is a logistical company. It's logistics issues that bring home health down. And I found that so very insightful, because it does not take a PT, for example, to be a logistics expert. It does not take a office manager to be a logistics expert. You need to determine who your logistics experts are, and when you logistically look at a situation in a different light, we tend to be clinicians. We tend to look at that patient with their impairments and what we can fix and what we can't fix. But sometimes you need somebody with that logistical mind to think, okay, what are our resources and how do we best get them to that patient? And that's a little bit different conversation. It's a little bit of a nuanced conversation, but it needs to happen. And and one of our attendees is saying, yes, I agree that nursing has been conditioned to go do the visit, harmed by reduced power to make clinical planning decisions. Absolutely true. We need to look at, but understand, CMS is watching. The data is speaking to CMS in real time. So when you look at what we're using as our resources, back when we were per visit, they knew that our outcomes were identical no matter how many therapy visits we gave them, which told them that we were gaming a system to get more revenue. Hence, the visits went away. They know what happened with PDPM in October of 2019, that there was literally a what's the word, bloodshed, um,
Mm-hmm.
in the rehab spaces to the therapy staff. They know the same thing occurred from January 1 to the start of the pandemic in 2020. There will be repercussions for that. So some of these decisions that have been made with short-term goals in mind, they're going to be addressed, and you're going to see a lot of things being written, and a lot of agencies that are going to be in some real trouble, based on some decisions that have been made. So we need to have those clinicians with those business type organizational minds come to the forefront and be willing to lead. We have some serious issues with clinician shortage, particularly with nurses and aides. That will also have to be addressed, but the studies are out, guys. 9 out of 10 seniors want choose home health to go
Yes.
through. 9 out of 10, that's 90%. So that's the kind of pressure that's going on out there. And so getting these primary care providers, the ARMPs, the PAs to be your partners. If you have a physicians group that is concentrating on that in your area, I would suggest a phone call, a meeting, coming together to see how you can help each other, because they don't want to make more visits than they have to. And if they can partner with home health agencies to provide that hospital at home type care, they're going to be excited to do that. Cindy, did you have anything else that you wanted to say about value-based services? Because I have a couple of questions that are specific questions.
Well, one thing I'd like to add to what you just said, and then we can go to the questions, is, a lot of people looking at the utilization data that was in the 2020 proposed rule and the drops, particularly in therapy, were very quick to say, oh, it's the pandemic. I do think the pandemic was a contributing factor. I think that we had issues with ALFs not allowing therapy in, patients feeling that there were too many services coming in presenting a risk to them. And so they were limiting who they would let in at all or how
Mm-hmm.
often. But I think if an agency right now, if it was me, Sherry, and I'm saying, okay, maybe I need to reevaluate, maybe I cut a little too far on the therapy and I need to course correct. I think the essential grace period CMS gave by here's the data, here's what we see. We're going to give you the benefit of the doubt at the moment, but you're right, we're still going to look at this. I think if our therapy utilization increased appropriately in the remainder of 2021 into 2022 as an industry, I think it would be seen as a rebound from the pandemic and not necessarily a PDGM course correction. And yes, I know we're being recorded. I'm saying if we realize we may have gone too far, the ability to change that appropriately and include that definitely the pandemic was part of it looks like an appropriate course correction, as opposed to some of our, the industry peak was 6 to 7. Let's make a 10 visit threshold. Now everybody got 11 to 13. That stuff looks blatant to CMS. But I think with the pandemic, and rightfully so, there are multiple things that have influenced how we utilize all of our services. So reevaluating that, because we're not out of the woods yet with the pandemic anyway,
Mm-hmm.
but reevaluating that data and say going forward, what do we want this to look like? How are we going to best manage this? Wouldn't necessarily look like it historically has, is some sort of financially driven course correction. Does that make sense?
Absolutely, and I think
Okay.
that they're parsing that data now, and
Mm-hmm.
they've been pretty clear that they're not going to be looking from March to probably August 31st. Everything, the TP&E audit started on September 1st, and they're and pre pre-billing audits of TPE. I was on a call yesterday. Pre-billing audits of TPE will start from 9/1 forward. There will be nothing going back on the pre-billing audits. So I think that they're using that pandemic
Right.
time as an anomaly, but they did have 2 months of data, and so there are reviews, and they've specifically said that they are starting from March 1st backwards, March 1st, 2020 backwards. So the fact that they can pinpoint that date tells me that they know exactly what happened and
Yep.
what was being set up to be a large exfoliation of therapy, if you will, from agencies. And
Ew.
yeah,
Exfoliation of
yeah,
therapies? Yuck. That sounds awful.
that does sound awful, but
Ugh.
it was so drastic, and it was
Oh yeah.
drastic under PDPM, and it was drastic under PDGM. I mean, the things that we were seeing on the social media outlets, and the things that we're still seeing in some areas about the number of visits that they're allowing and things like that. Trust and believe they will find you. Trust and believe that they use that data in a way that is an analysis that can pinpoint and target what audits they're going to do. And so I cannot tell folks that they need to be looking at their own data. Cindy, I'm going to get on my soapbox. Look at your own data and look at it against the benchmarks. There is a home health chart that's put out every year by AHQI that shows the average number of visits, that shows the average, based on different diagnoses and things. Make sure that you compare favorably to some of those things, because if you're an anomaly, if you're an outlier, they're going to find it and they're going to ask why, and their form of asking why is sending ADRs and things like that. So just be aware that those things are occurring currently. And folks that think that they're, oh yeah, they're not going to look at anything in 2020. No, they're looking at January and February in 2020. Let's be really clear. They're looking at that in home health, just like they're looking at the PDPM data from October of 2019 till March 1st of 2020. Um, Cindy, real
Yes.
specific question as we're getting towards the end of our call. Can you remind the folks, if an ST can admit to home care, can they stand alone, or do they have to have another qualifying service like OT does right now?
Well, I think some folks may say, is that really a question? Yes, it is, because there's still a
Mhm.
lot of misunderstanding about this. Speech language pathology could admit patients to home care before the pandemic. This has nothing to do with waivers or COVID. Their situation has not changed. Yes, a speech language pathologist can admit a patient to home health. Let's get real crazy, Sherry. If, say, speech and OT were ordered, speech would do the admit. If speech and PT were ordered, wait for it, either one could do the admit. I know we've
What?
always said it goes to PT because no, in a case without nursing prior to the waiver, um, in a case without nursing, it wasn't a PT had to. If speech was included, speech could do the admit as well. The challenge I think organizations have faced is it's hard. It's been very hard in most situations to have that much speech therapist. I stand by my statement that there's only 5 speech pathologists in the country doing home care, and everybody's trying to take a piece of them. So operationally, I've never really seen it a priority necessarily to push the admission issue because there's so few of them and their time when you have them is so limited that it's typically weighed. I'd rather have you able to see 2 patients or work with 2 patients than to do 1 admission. But from a regulatory standpoint, they can do that admission and they can be the only one ever in there. And I'm going to get real crazy, Sherry. They could also get an aid in a speech only case
Stop it.
because the aid is not tied to the nurse at all with respect to any therapy case if the patient needs an aid. But even if there is no PT or OT, an aid could be on that plan of care. And yes, the speech pathologist could do the oversight.
Stop it.
I know. I went crazy there.
That is radical. Okay, last question. Da-da-da-da. I'm sure that you guys may have some questions that come up after this. Please take a moment. I put up our slide, and you may notice that my picture of my big head has taken the place of Dee Cornetti. Dee Cornetti is actually gone to start her PhD studies at the University of Florida. She is still part of Cornetti and Craft. It's just a little bit less on a day-to-day basis. And so I will be taking her place on the Q&As when she's not available. And today she was not available. She's actually driving back from Gainesville. So I figured I'd throw a picture up there since most people don't even know who I am. And that lovely picture of Cindy looking very, very school picture-ish over there. Last question. What suggestions, and I'll start, Cindy, I'll start with my first three suggestions on how
Okay.
agencies can prepare for value-based purchasing. My first suggestion is that you make sure every clinician in your agency knows what the outcome measures are that they're going to be looking at. Many times I've seen Dee and Cindy present all over the country, and when they ask the question of what is one of the most important outcomes that are measured in home health, very rarely do people understand that it's rehospitalization. Very rarely do they answer that question correctly. So number one, I would make sure that all your clinicians and all your office and anybody who touches that patient knows what the outcome measures are and knows that they're going to be being measured. Secondly, I would be very, very sure that that the information that you get on the start of care and the plan of care that you provide to the physician, that it is accurate and that it is measured correctly. Many times you're going to shoot yourself in the foot because you overestimated what the abilities of the patient are. And then when it comes time to do the discharge, you go, oh no, they declined. Well, if they're measured wrong on the beginning of being too able, then they will decline. Thirdly, I would do a look back of my information that is audited and reviewed, and make sure that my clinician is a part of that, and make sure that again that they're trained and know how to do those measures at the beginning of the case. Cindy, go. What would you suggest?
Sherry, you took nearly all of mine in essence. I think, no, I think a lot of folks are viewing preparation as understanding the model. I think from a leadership level, yeah, you're going to need to understand what's calculated, how it's calculated, what the composite is, all that other stuff. I get it. But I'm seeing a lot of value-based purchasing prep being that. And back to my who's driving the train, the clinician is going to make or break your value-based purchasing outcome.
Yes.
They just are. And their disconnect. Again, I think we fragment it. We say absolutely the OASIS at the start and the OASIS at the end have to be answered correctly. And we want to make sure that folks do that. But there has to be an intentionality in that care plan in between. So what I see is you've got LPNs, you've got PTAs, you've got OTAs that are actively, and social workers actively working with individuals that have never been to an OASIS training, do not know what these items say, do not know what the response options are. And I'm not saying they all should be put through intense training, but if they don't understand the terminology of continuous versus intermittent assistance, if they don't understand that wonderful transfer issue of the and versus the or, then they're not thinking that way at all. And so they're doing what they would normally do without an eye toward that. So just a quick example, Sherry, the functional improvement items. If the improvement in ambulation and the improvement in bathing most often hinge on continuous versus intermittent assistance, and I as a therapist function in my therapy way because OASIS is discipline neutral data assessment, not therapy. So I'm talking about, well, he started out bathing with moderate assistance and he ends up with supervision. Well, oh gosh, he still needs assistance. He's a 3. Wait a minute. But that supervision is actually intermittent.
Mm-hmm.
It's not for everything. It's only for parts of it, but I don't document it that way. I'm not thinking about that. The OTA that worked with them didn't ever write it that way. Nobody thought about that because that's not how we're wired. That's a disconnect we're going to have to deal with, that we should have dealt with a long time ago, because none of these are new outcomes. I mean, everything's been on here forever, but we got to make sure the clinician understands, not from a beat down, value-based purchasing is coming and it's all your fault. Okay, hold on. What are we doing? Let's focus that care plan. Let's integrate some of these terms so we're focusing on it throughout the course of care. And then this just becomes part of doing your normal stuff. But
Mhm.
it's paying attention to those key things that, quite frankly, from CMS's perspective, they thought we were paying attention to this the whole time, which is why they think value-based purchasing is no big deal. These are already things you measured. These are already things you did. So starting data collection in 2022 shouldn't be anything from their perspective. If we are
Yeah.
anxious about it, we need to make sure our house is in order the way you just described, Sherry.
Absolutely, and guys, we've run out of time. And thank you for bringing up my word anti-exfoliate, Cindy. I really appreciate that. Cindy
Well, I
Moore
think
on.
some people, I just keep thinking now, as you kept talking, I kept thinking about exfoliate, and some people took that loofah a little too aggressively and
Oh
kicked out too many visits. Now they're bleeding. Might want to
yeah.
fix that.
Oh, absolutely. And someone asked me to repeat what I said about value-based purchasing, so I'll say it again really quickly. Make sure that your clinicians understand what the outcomes are and what the agency's goals are for that outcome. I like to use an analogy with sports teams. If a sports team doesn't have a goal of a championship, which in y'all's case in the home health, the championship is the outcome, then they have a hard time with all the steps to get there and all the things that you may be trying to innovate to get there. So make sure that they understand that you're shooting for appropriate outcomes and what those outcomes are. Secondly, make sure that the information that you're getting in your first couple of visits and as you do your plan of care, make sure that it's accurate. And that's where that interdisciplinary plan, care planning comes in, Cindy. What happens? What have we been dealing with for years ever since the OASIS happened? The nurse measures differently than the therapist, correct? Well,
Yep.
golly, what if they talk to each other? What if they had a conversation? When we had our agency, and I'm sorry if we're going over time, guys, but when we had our agency, we actually had a start of care team that went out on the weekends, and it was awesome. We had a nurse and a therapist that enjoyed working together, and one of them is actually on this call today, and they did a fantastic job on the weekends, and it was the best thing ever for Monday plan of care for what happened over the weekend. Wow, it was so succinct and to the point that our patients were given the best possible care on the weekends, which kind of made us stand apart. And thirdly, I forgot what I said thirdly. Cindy, do you remember?
I do not. Oh gosh.
Thirdly, doing the look back, making sure
Yes.
that when your auditors are looking at your paperwork that comes in from your clinicians, that they are all singing off the same sheet of music. And the only way to tell that is to do intermittent look backs at everybody. And thank you, Carol, for saying that weekend with the nurse for starter care was great. You guys were a great team. So thank you guys for joining us. We will be doing this again in November. We'll try and avoid the week of Thanksgiving and we'll set it up. It'll probably be on a Thursday. So look for the date for our next one. And please, if you have questions that come up in between there, do not hesitate to email us. Or if you receive our newsletter or our email blast daily, just respond to that and let us know what questions you have and let us know what questions you want us to have on next time. Thank you guys for joining us. And again, take care of those patients and take care of each other, and we'll see you next time.